order chromosomes. When would we want that now?
If the chromosomes don't grow, then we want microsomes. You can't be the order.
No, it's not every member of your staff.
The
person who's getting the low press skating.
With their hand on the door.
Yeah, one who doesn't sit down, it's that person, they're not in the room today.
Today we have a wonderful speaker for we have Dr. Aziz Baruchi, who is an endocrinologist and is an attending professor at Memorial Sloan Kettering. He's going to talk to us today about osteoporosis and diagnosis.
Thanks, Doug. Thanks for having me back, everybody. So it's a subject that we all know and love, hate, whatever, get sick of at some point. So I really want to keep this discussion here very clinically relevant. I don't do lab research or anything of that nature, so I see a lot of patients like you guys. You're all very sharp clinicians. I've been here before. I know that. So we can take discussion anywhere we want to take it. I know there's some hot topics. Drug holidays, I think, has definitely become one of them for bisphosphonates. And the National Osteoporosis Foundation actually has really in their latest guidelines said that the therapy is necessarily forever. So they really are, definitely endorsing that concept of getting a holiday from especially bisphosphonate drugs at some point. But we can go through some of these things, how to interpret bone density scans. Is anybody using these blood and urine test bone turnover markers? They're pretty esoteric, those are things you can order. No, you don't have to, but they give you a sense the patient is being compliant with bisphosphonate and it's being absorbed, an oral bisphosphonate, really. Go through some other stuff. Is anybody using the FRAX calculator? Yeah, that's not too bad. You go onto the internet. If they have osteopenia, you put in their numbers, their clinical history, their demographics, age, and then you get a fracture risk over 10 years, and it's identify who needs to be treated in that huge pool of osteopenic patients. Oh, the FRAX app, cool. Yeah, I didn't know that. Yeah, that's excellent. And then, we can talk about the calcium supplement controversy, guys getting the pushback from the patients on calcium supplements and whatnot. Yeah. What's that? Well, so
they wanted
Cardiac.
Cardiac. There's been some studies that have linked it with high risk of MI and cardiac disease, calcium supplements, postmenopausal women. So I think that's debatable, but I am, encouraging people to just get half of the 1,200 milligrams that's recommended if they can from food. If they want it all from food and whatnot, that's fine too. What's that?
Friday. I just 2-3 days a week.
I see, with the calcium supplement.
Exactly, because
yeah,
no problem with hypercholesterolemia, they're on just to be on the side.
Right. Now eggs are okay again, but that's a separate topic. But so we could talk about drugs as well. And we appreciate that osteoporosis, the point of screening, the bone density is a great screening test. And it's because osteoporosis is basically silent, doesn't cause pain. Patients are always linking it with, arthritic symptoms and whatnot. But it's like hypertension would usually be silent, or hypercholesterolemia would usually be silent. And the thing is, it's not only decreased bone density, but the architecture of the bone is compromised. So this is an 84-year-old lady there on the right with the architecture. That's a vertebrae. You can imagine that would be much more easy to compress. Why am I stuck here? Let's see. So I think it's stuck some. Yeah. Let's see if I do this. Uh-oh. I'm trying to escape, but that's not working. Oh, there we go. Finally. Okay. So this is one of these slides that shows how common osteoporotic fractures are. my disease is bigger than your disease kind of thing, right? So if you look at the incidence of osteoporotic fractures in the blue, it's more heart attack, stroke, and breast cancer in combined, and get their share as well. So the most common fracture is the vertebral fracture, and a lot of these actually are asymptomatic, something like 2/3 of the spine fractures, so that leads to loss of height in the long run and whatnot. But the hip fracture is really the one that's most devastating, right, because that has been associated with a 20% mortality at 1 year, and then people may lose their ambulatory status. So I think a lot of patients, anybody would want to avoid going into a nursing home type situation and all that. So this is showing us vertebral fractures, kyphosis, although a lot of people with kyphosis don't necessarily have vertebral fractures, right? They could have scoliosis, they could have degenerative changes. But this is how you actually tell. Somebody comes to you like that, you can get lateral spine X-ray, you can get an MRI, whatever you want, but the lateral view is really better to see that compression right there. And this is somebody with a T11 compression deformity. When somebody has one of these, it increases the risk of future fractures. So it's something that if somebody has a lot of height loss and you're not sure whether to treat them, it might make sense to try to find that. Radiologist sometimes comments, sometimes doesn't. So this is, what we know is normal in the osteopenic. And this is comparing to a 30-year-old. You might say, well, that's not fair. But the thing is that, if you have average bone density for an 80, 85-year-old, that's really not so great for fracture risk, because a lot of 80, 85-year-olds break their hip. Okay. So this, again, showing us that the lower you go on that T-score, right, you keep exponentially takes off in terms of the fracture risk. Right? The lower the T-score, the fracture risk. And you can see around -2.5, it really is starting to go up. Now, the bone density scan. So, there's 3 sites you could measure, three standard sites, and then the distal radius. If somebody has hyperparathyroidism, we would get that. If we can't use either hip, something like that, we might get that as well. I want to make the point that when you're interpreting these things, it should have this error margin on the report. So in other words, if I get on the table and I get off 10 times in a row, I'm going to get 10 slightly different numbers, because anything we measure, right, it's not a perfect thing. The way they position you, the calibrate. So there's an error margin, a precision error to the measurement. And technically, each center has to use method to calculate that. So at Memorial, we have these numbers that we've come up with that use percentage change in bone density, not in T-score, but in bone density of this much to be significant. And it should tell you on your report what your percentage changes is to be significant. Sometimes they just default to what the manufacturer has instead of actually calculating it. So if you guys do bone density here in the hospital, there's an organization called the ISC, and they have a very easy method to follow to calculate your precision error. So that's really what should be done with the technologist and the machine and everything.
Computer and your FRAX score does not indicate a requirement for intervention.
Yeah.
And on the follow-up scan, it's not osteoporosis.
Yeah.
It's not a significant change. What do? Do you say there's no significant change, or do you now intervene because it's in the osteoporotic range?
Right, tricky. I think, if they're hitting the osteoporosis mark, I would probably treat them, give them a course of treatment, because they're right on the borderline there. It depends on, if you think the patient's not being the textbook in terms of their risk, and they're very young, healthy, young, no fractures, their parents didn't break, didn't have any fractures, you could wait. Wait a little bit. But if the patient's a little older and higher risk elements in their history, then I would go ahead and treat. That's a judgment call. That's a good question, though. you know, you may oscillate up and down. And, you know, we'll look at how the hip rotation changes that, because, you know, the patient may lose bone density. Now the next time it's magically back up, so they're where they started originally, you know. And I tell them it's like the stock market. Sometimes you have to look at the big picture, right? Because you look at the short run in the stock market, you get fooled. So you have to look and see where the trend is going sometimes to get a clear picture of what's happening.
And in the hip, do you look mostly at the total, or do you look at
the femoral neck? Both. I mean, I think that the femoral neck generally has more error that can be associated with it.
the femoral neck will come back minus 2.5 or minus 2.6, and then the total will be normal, like not normal, but minus 1.6 or 1.7.
Yeah.
So what do you treat? Do you treat the femoral neck, or do you treat the bone?
So if you have osteoporosis at either site, you do.
Either way.
Yeah. So this is an example of that least significant change thing that we were talking about. That the bone density, if you look at so the T-score now has gotten worse. The bone density, absolute bone density is lower after 2 years. Now the difference is 1.5%. The significant change is 2.4%. So that is not a significant change. I mean, the overall message here, though, is that, you know, the bone density is a great screening tool, and track it constantly, then you get into, you know, situations like this, patients obsessing too much. I mean, if you have a clear downward trend and the patient's on therapy, that's not what we like to see. So we wonder, is it the drug not being absorbed with bisphosphonates, especially, the patient's not compliant, what's going on, and that's where these bone turnover markers sometimes are helpful too, in the blood and the urine.
You still do them every 2 years?
Density, I mean, well, that's a good question. That's changed.
You know,
Not necessarily. Yeah. I mean, if somebody has mild osteopenia, it's the data that, you know, you can wait 5 years or more, you know, because it's very unlikely to progress. Some of the people I see on aromatase inhibitors for breast cancer, you know, they can lose a lot. Somebody's on steroids, they can lose a lot too. You know.
Aromatase inhibitors, do you do those every year?
We do in the first couple of years usually, yeah, and then you could back off for longer. But yeah, the first 2-3 years somebody is on those drugs, they can lose a lot. It's like a second menopause kind of thing.
Do you automatically put them on something to affect their bones, or?
Not automatically, but you know, the threshold is lower in my opinion, definitely. You know.
What was the threshold? Like 0.0?
You know, it's hard to say. I had a discussion with the patient. I mean, I look at these bone turnover markers too, but if you know, FRAX risk, first of all, if they you know, if their FRAX risk is not high, it probably won't be high enough in a lot of these people because they may, you know, let's say 60, they have some osteopenia. So you could wait if the patient's kind of like, oh, I don't want to. I talk to the patient. I say, well, you know, you could lose bone here. I would suggest you get some treatment, but I'm not going to try to force you. We can wait here, and if they lose a lot, then say, okay, let's do it now. Yeah, in those patients, we are more aggressive. So this is an example, though, of how the hip rotation influences this, because you can look at the image before and after, and it doesn't, you know, this seem like much different, but the trochanter is rotated slightly different. So first of all, the femoral shaft should be straight. Sometimes you see, you know, they have like really at a 45-degree angle, and then you're comparing apples to oranges. So that's going to be unreliable to compare before and after. Okay. So this patient, let's say, you know, they had a loss of bone density at the hip, it looked like, and they had stable at the spine. And so you can ask the center to redo it if you really want, but that's the problem, is that, you know, they have to really, the amount of the trochanter that's seen, the lesser trochanter should be about the same to get an accurate reading. Yeah. That's another one that's, well, our guidelines are not to treat based on the forearm. Yeah, you don't have to treat based on the forearm. But I get a parathyroid hormone level in that patient.
And you're worried about this putting off the bone, right?
Yeah, there's cortical bone here, you know, that a hyperthyroidism chips away at, that hyperparathyroidism chips away at, so yeah, I wouldn't use that as a sole site to treat based on,
The radiologist reads it as osteoporosis.
As osteoporosis.
Yes, right.
Yeah.
I have called them and they say that. The guidelines are that they have to call it. But you're putting in your FRAX is your neck of edema.
Yes.
T-score. So with that, your numbers are very good.
Yes.
But they call it, so.
Yeah, it's true. I mean, I think I would tell the patient that the guidelines do not recommend treatment only based on this. But, like I said, I mean, you could make sure they're not hyperthyroid, hyperparathyroid, if that's the case. So, this is just making the point that there's these the bone density is one thing, and then there's this bone quality concept. It's a more, intangible. So normally the old bone's taken out, new bone is put back, osteoclasts take it out, osteoblasts put it back. It's constantly occurring, very, very active process, very energy-consuming process, and it related to damage repair. That's essentially how a lot of these therapies work, is that the anti-resorptive specifically, they lower bone resorption, and they to balance back in a neutral balance. After menopause, this is classically what we see. There we go, okay. So, and again, bone structure, you can see here that these horizontal connections are dropping out, and that's what makes the bone weaker. So it's this web-like structure that gets weakened with time. Except here that if you have more of these horizontal connections, that structure over there on the left is 16 times stronger than the structure on the right. The fine architecture here, which the machines that can do this cost a lot of money, millions of dollars. So,
you earlier slide mentioned rheumatoid arthritis. Do we have different thresholds for treatment in the presence of rheumatoid arthritis?
Yeah, rheumatoid arthritis is in FRAX as a major risk factor, and definitely lower my threshold for treatment. So, technically, if they have osteopenia, you can put it in FRAX, and that will show you, give you some guidance as well. But it's tricky. A lot of times they may be on steroids as well. So that's another thing. So we all gain bone up until the time we're 25 or 30, and then you lose little bits of bone with aging. But that's another thing. I joke with my patients. I'm like, aging is a terminal disease, really, because we all lose bone with age. There's nothing you can do about it, really. That's not the goal of therapy, is to restore your bone density to, a 20-year-old or whatever. The goal of therapy is to prevent fractures. So when we see that low bone density, there are contributing diseases that can contribute to that, and we should be aware of those, I think. One thing is, rickets in kids is the same as osteomalacia in adults, and that's not that's different from osteoporosis in that it's not an architectural thing. It's there's not enough mineral in the bone. So people with severe vitamin D deficiency, people who get no calcium intake or who cannot absorb calcium well, they can have low bone density because there's not enough mineral in there. Classically that causes low calcium and low phos, but it may not be. And people will have tender bones, like if you push a tibia or the sternum, oh, that hurt me. No, I'm just kidding. The bone density is a little bit dumb test in that sense that it doesn't tell you about the architecture, but it tells you about the density. So these are the other things that can contribute to bone loss: celiac sprue, thyroid, vitamin D, parathyroid, myeloma, can definitely do it. Just disease rare, Cushing's syndrome. Somebody's on steroids, more than 5 milligrams of prednisone a day. In men, low testosterone, and I've seen some cases of methadone and opiates causing low testosterone in men. It could be happening in women. RA, like we said, sometimes you can have situations of too much calcium being lost in the urine. and COPD, weight loss. Weight loss is something that I often find may cause a loss of bone density. And, you know, if somebody's obese, that obviously you want them to lose weight, so that's okay. You know, if they exercise while they're losing weight, it may mitigate that a bit. Some medications here, you know, I want to just highlight the proton pump inhibitors. It's a slight increase in fracture risk in a lot of associative studies, epidemiologic studies. But, I mean, people just get stuck on those forever and ever, and there's no reason they should really be on them forever. When I talk to gastroenterologists, I was surprised to learn that there's really no data that, you know, you can prevent Barrett's esophagus by being on a PPI, or prevent esophageal carcinoma being on a PPI. Now, if somebody has Barrett's, maybe that's different, and they want to get permission to go off of it. But, you know, the drug is completely benign. So the fracture risk factors, the main three are the low bone density, prior history of fragility fracture, and age. You know, the older you get, the higher it becomes, okay? So these are the other things that go into FRAX here. Well, let's look at age. So, you know, if you look at somebody with a -2, at 50, the risk is lower than when they're 60s and 70s and 80. So the fracture risk is going up there at any given T-score. Okay? And now, if you had a prior fracture, so if I fall down and I break my wrist, it increases my risk of future fractures at any site. Logical, right? By the way, feel free, if I say something doesn't make sense, just disagree with me, and we can figure it out, you know, because a lot of times though people say, well, I know hard. I mean, nothing's 100%, and you know, it wasn't related to skeletal fragility. But if somebody with low bone density falls hard and they break something, I tend to believe it's, you know, a sign that they have some skeletal fragility. Osteopenia. Okay, so I'll just walk you through this quickly. The fracture rate is the yellow. So if you go to the osteoporosis over there, that's the highest risk or rate of fractures. And the bone density, of course, is normally distributed, you know, like a bell curve. Now, where do you think the highest number of fractures, absolute number, occurs? It's in the osteopenic zone. So that was the whole point of FRAX, is that, you know, there's so many more women with osteopenia and men than don't have it, than have osteoporosis. We need to identify those because there's more fractures that occur in that population, actually, by number, by sheer number. So thinking was you just use a cutoff for the bone density, you treat based on that. But, you know, with the FRAX, it's a little more, you know, based on clinical risk factors as well as just bone density. So, in fact, a lot of countries don't have the bone density genes on every block like we do, you know. So you can put in body weight and surrogate for hip bone density, actually, and if you don't have the bone density, believe it or not. We live without a bone density, oh my God. Yes.
Because I know it only uses the femoral, the hip, and there's so many times that I have, you know, a pretty low, you know, osteopenic range for the hip, but then the vertebral core is really high. It's like a minus, you know, 2 or something, and the hip be like a minus 1.3.
Yeah. So, you know, technically, then you shouldn't treat that patient, but you make a good point that there's been some, you know, corrections for very low spine bone density that have been proposed. You know, what do you do if it's minus 2.4 at the spine or something? If osteoporosis at the spine, you're still supposed to give that patient a course of treatment. Yeah.
You know, and just when you calculate it, it kind of gives you a full sense, you know, like their percentage will come out really low based on their maybe higher.
Yeah, that's true. Yeah, I mean, still, you know, if the spine is osteopenic, so now there's not, you know, the thought is not to treat it just if they're osteopenic at the spine. You're right. I mean, you know, say that their FRAX is like, you know, 18% and 2.9%, and the spine is minus 2.4. You know, use that. This is just a guide. You could say, well, look, you know, that's swaying us in favor of treating because your fracture risk is probably higher than FRAX is telling us, you know, at your spine.
When you get, you slow and you have like spinal score that's like minus 2.7, and then all of a sudden it's great because there's compression and it's worn down.
Yeah, see that?
That's not really articulated in those reports.
Right.
It looks like it's all of a sudden they've gotten better when really it's.
That's a very good point, yeah. And I mean, you may not be able to see that on an AP view. I mean, some of the DEXAs have the VFA you can order, it's vertebral fracture analysis, and it's lateral view, and they look at the whole spine, and they should pick up, hopefully, compression fractures there, and tell if there's compression deformity. Oh, that's not perfect either. Yeah. So, but if you're a DEXA with VFA, you know, you should get some sense, if you're worried that the patient had a compression. But that's exactly right, because if you get a compression fracture, your bone density actually goes up, because the area is smaller, right? So these are the things that go into FRAX. Ask the patient whether their parent fractured a hip. It's another thing. Smoking, alcohol, steroid use of 3 months or more, past 3 straight months. Do you have anything else on this? And they actually take into account ethnicity.
What's the check for this prednisone? Is it like a year ago, 2 years ago, 5 years ago?
It's technically ever. You know, I think you've got to take it with a little bit of clinical grain of salt, and you know, if it was 30 years ago, patient never had a fracture, okay, you know, it is what it is. But I think oftentimes, though, somebody they get treated off and on with steroids for asthma or whatever. Some, you know, questions about that. Usually it's thought of as 3 months straight of steroid or not. Also steroids at the high dose, you know, have been shown to be terrible for bone, but my suspicion is that they are, you know, not good either. So let's get into our treatments here, and then we'll talk about the drug holidays and all that. So, you know, basically you can see here that anti-resorptives, which is lower bone breakdown, lower osteoclast activity, really what we've got at this point. Estrogen is one of those, SERMs are one of those too. Calcitonin has been kind of discarded because it's, first of all, it's so weak, really barely did anything. Second of all, may increase the risk of some cancers in a very large analysis, which is a big surprise. But our non-pharmacologic therapies here definitely look at the patient's mobility and balance. I mean, I really try to pay attention to that. Because if the patient's going to be falling, you know, that's putting them at risk for hip fracture. So I refer to physiatrists, physical therapists, stuff like that. You know, I ask people to try to stand on one foot for 20 seconds with their arms crossed like this. And if you can do that, you know, it's considered pretty good balance. So if somebody can't get up from a chair without using their hands, that's a fall waiting to happen, right, because their muscles are weak. So it really makes sense, I think, rather than, you know, trying to use a drug to everything here, to pay attention to these factors and get these patients referred, you know, to appropriate people to try to keep their balance in good shape.
I found that referral base kind of hard to find in the local area. You really need to kind of reach out to the nurses and figure out if they're comfortable with the treatment of osteoporosis.
Yeah, I think most of them would, you know, in terms of balance. And the other thing I tell physical therapists is try to strengthen the paraspinal muscles, you know, kind of for like that, and you know, it's, I think they would be okay with and just, you know, they would look for any muscle weakness, you know. The physiatrists are a little hard to come by, huh? Geriatricians are actually quite good at this too, because all, you know, everybody that's elderly, you know, most people that's elderly have a risk of falling.
In our group, the
physiatrists and physical therapists are very active and vocal about their ability to treat this, but that's mostly non-physical based.
Yeah, I hear you. Yeah. Anybody using Dinomab or Prolia? This is a shot every 6 months. Yeah, usually, that's
What's the bisphosphonate?
yes. The net result is the same, but there's some difference, some subtle difference. Yeah.
You have to have the discussion. Osteoporosis and atypical.
Yeah.
Am I correct that the 2 patients in the study were previously on this?
No. Yeah, they weren't.
No, they weren't.
So Prolia can cause atypical fractures, yeah.
No
Are the
difference
frozen
between.
bones, the frozen that we saw with the bisphosphonates also?
Yeah.
6 years?
It can happen. I mean, it's very rare, but like, Doc's saying here that in their long-term study, they had 2 cases of these atypical femur fractures. So it's
But the osteoporosis ain't atypical with that thing previously on?
ONJ can happen with Prolia without any bisphosphonate exposure, yeah. Not in the clinical study, though. In their clinical study, they didn't find it. But, well,
Is it safe?
Scientists really know it's not safe, but biologists use it. I don't know if it's any safe. Safe.
The bisphosphonates, I always think like they're wasting away. Their
Like they sit in the bones forever.
Whereas with the rancglycan.
yeah, that's the difference. That's right. Is that the bisphosphonates are very sticky, and they will have a persistent effect. The effect on lowering the bone resorption, we can measure it wear off though. It does wear off. Alendronate, Fosmax is one of the stickiest. Reclass is extremely sticky, and I actually dose Reclass based on when it looks like it's wearing off. But the Prolia, if 6 months later, if you don't get another shot, so let's say you take Prolia for 2 years, you build up your bone density. If you stop it, the effect, your bone density falls. So it really just washes out immediately, and you pin that as a good thing. Because say somebody needs to get a tooth pulled, and you gave a shot of Prolia, and they need to get a tooth pulled. Now it's 4 months later. You could say, all right, well, the drug can be washed out in 2 months. Why don't you do it then? In theory, that would be a good thing for any risk of ONJ.
What do you mean you dose your reclass?
So Reclass is supposed to be once a year. That's the FDA-approved frequency. So what I find is that the markers sometimes stay down and stay suppressed at the 1 year mark. So it's indicating that the drug is having a very vigorous effect still. So I would not give another dose. I would do bone density too, but yeah. I mean, I think that's kind of something that bone people get involved in, these bone turnover markers. Sometimes the insurance doesn't pay, and great drugs, I think, for people who are about 50 to 60. There's no hip fracture. They weren't able to show the drug prevents hip fractures. It's a little weaker of a drug. That would be the reason. It doesn't increase bone density. It doesn't lower bone resorption the same magnitude that bisphosphonates or Prolia or whatnot do.
It's like Duvee?
Yeah, well, Duvee is a serum estrogen. That's an interesting option. Evista, is the classic serum diet, right?
Sure.
You knock on any of these is DVT risk, right? And then in the Evista study, this is something that the patients, pending they either left or get freaked out, is that there was, if you had a stroke, it was more likely to be fatal. So the fatal stroke in the Evista study was a little higher in the Evista arm. So people might say that, well, yeah, if I have a stroke, I don't want to live anyway,
Okay.
That study was in women who were very high risk for heart disease. There was the ROOT study, right? And so I tend to assess cardiovascular risk. If somebody's it's very high risk, smoker, high cholesterol, hypertensive. Maybe you want to be a little more careful about giving them Evista. You can't give it if you had a blood clot in the leg. You know, I tell people if they go on a 6-hour plane flight, get up and walk around. You know, it's good advice anyway, right? You know, that's a serum, yeah. Yeah.
They keep hinting, you know, we can't talk about this, but, you know, trials.
Yeah, I'm not so familiar with that, sir, but I mean, it probably is common issues that any estrogen-like agent has with the DVT and
it's mostly like that's.
yeah, I mean, if they have any data on bone density and bone turnover, those are pretty good surrogates.
No, they won't give it to you.
No,
Oh, yeah,
They'll
oh, really? Okay, that's interesting. Yeah, I'll have to look into that. There is the one anabolic drug we have. There's another one that's coming from Amgen that's really very eagerly awaited. So the anabolic that we have is Forteo, right? And you can only use it for 2 years, and then you kind of have to chase it with an anti-resorptive to lock in the bone that you built with it. So with the issues with the osteonecrosis of the jaw and the atypical femur fractures, those are, like we said, bisphosphonates and denosumab. But with Evista, it's not an issue. With Forteo, in fact, Forteo can help bone healing in the jaw. So that's an issue whatsoever.
etiology of it, is it because the bones get so dense that it just like what happens?
The femur fracture?
Yeah.
You know what? It starts as a stress fracture. So I'll show you some pictures here in 1 second that it starts as a stress reaction. So what it is normally, I think, the damage that we all get in our bones is able to be healed. But in some people are susceptible to when they're on these drugs, 1 in 5,000 after 10 years of Fosamax, let's say, are susceptible to not being able to heal that damage, and the stress fracture takes root and it propagates. And you know, that's a disaster, so obviously take it quite seriously. So I was saying that, you know, if you look at raloxifene, there's no hip fracture data with that agent, but all of those other ones, including denosumab, very good anti-fracture data. So, you know, this is the thing is that we take these side effects seriously, but these are side effects of long-term use. And so taking a course of therapy, the way I usually feel about it, 3-4 years, you know, nothing terrible is going to happen to the patient. You know, it's very low risk situation. So the risk of fracture is much higher in somebody who needs these drugs than the risk of getting a rare side effect if you take a course of therapy. So now I think it's important to realize that hip fracture risk, you know, later in life. So on, and they use an agent that prevents hip fractures in somebody who's at risk and who's older. So Evista, you know, all DVT risk goes up. So using Evista in a 75, 80-year-old would necessarily do that. Of course, you guys know better than me how good estrogen is at protecting bone. So using that as an agent after the menopause is a great option, I think, in somebody who's got hot flashes. What's that? I know, it's a shame, but you know, the data is that if you use it right, so the WHI was post, right?
But you can't talk to the internist and the hemoncs and the breast people.
We're all scared of it, yeah.
They're like, they don't even want them in the same room as them.
Wow. Even if they don't have cancer history. Yeah. That's bad. Yeah. Now, you know, things in medicine we all know swing, the pendulum, it goes back, and, you know, it's... So I think it's a very good option for women. I mean, I see some women have, like, a hematologic malignancy, their menses get knocked out, and, you know, definitely we put them on estradiol, you know, good dose. That's just physiologic. But the data suggests, you know, if you use it right after menopause, there's no increased heart disease risk, and maybe less, you know. Anyway, so this is something to keep in mind. And I have here like a typical sequence of therapies, right? So, you know, for the 50-60 crowd, you know, you could use Evista or estrogen. Then you could move on to a bisphosphonate if the fracture risk is has gone up. You could give a drug holiday from a bisphosphonate after 3 to 5 years. Then you could, if they're high risk, you could give Forteo, a very expensive drug. Then you want to chase the Forteo with a bisphosphonate or Prolia.
So why are you starting their screening test? You're like,
Oh, yeah. So, you're right. I mean, I happen to see if patients are getting bone densities because they're cancer patients and whatever. You're right. I would start at 65 with screening.
so many women come in, they've been menopause for a year or two, and, 50 years old, they're like, I want my dad.
The only way I would justify that is if their mom or dad broke their hip, they really, they already had fractures. They're just very, I think most of the time that's unnecessary. Because again, they're not, their age, so there's different arguments you can make. We all know you lose a lot of bone during menopause. So let's say you get that patient and now she has minus 2.5 and she's going through menopause right now. Well, let her lose. An old-time endocrinologist said, no, if you that patient that Merck's gotten to you, he felt that if you start low, you're not going to lose that much. But I don't think that's absolutely true. But, yeah.
Like 61 to 65.
Okay, question.
Not
Yeah. Yeah, so Prolia is a sensitive drug. It's effective, definitely. It's an option. I mean, it's meant for severe osteoporosis for the most part. Generic bisphosphonates now, I mean, that's one factor. I think 6 on one hand, half a dozen on the other. I mean, you could offer that as well, but it's generally, the approval was for severe osteoporosis. So if they have high risk, if they have a fracture already and they have low bone density. Yeah, I mean, you give reclass alternatively, reclass the IV, which is once a year, right? So, yeah, that's an option. I mean, but the other day I had somebody who was really not high risk who got put on Prolia, and I thought it was unnecessary. Why put on the most newest, most expensive drug when you have other options? Actually, I put her on a Vista because she was young. Yeah, you don't need that. Remember, though, when you stop that Prolia, you kind of have to chase it with something. Or the bone you build will tend to wash out. So vitamin D, it's not the fountain of youth necessarily. I mean, it helps with bone and it helps possibly prevent falls. And the elderly, there's data on that. But all these other things are all quite unknown at this point. I like to take some because we're probably meant to be outside more. You get sun exposure, et cetera. So let's talk about calcium for 1 second. So people go overboard on calcium. You'll definitely have a higher risk of kidney stones. There's no doubt about that because we know that from the WHI study. People think the more the merrier. They're taking calcium 3 times a day, taking a multivite, and they're getting tons in their food. They could get kidney stones. There's no doubt about it because you rid the excess calcium in the urine. That's how your body deals with it. Cardiovascular disease thing, the mechanism is really in question. I mean, nobody really understands why that would be. Again, in a renal failure patient who can't get rid of the calcium, and the calcium phosphate product goes up, and then you get ectopic calcifications, maybe there's something there. But the data is what it is, and the guy that did it is pretty credible. A lot of analyses, so it's really debated, and until the debate is settled, I think we should all try to encourage patients to get more from food. In the label, the fortified foods and the percent RDA, on Cheerios, for example, it'll say 10%. So you multiply that by 10, and that's 100 milligrams, because the RDA is based on 1,000. 1,000 milligrams is 100% of the RDA of calcium. Then you go on the internet and go to calorieking.com and put in whatever foods you want. And let's see.
3 times a year, I see patients who come in and have been told by their internal medicine doc that they have more motion, but an elevated serum calcium, so back on their calcium.
Now that's interesting. It may be that some of these people have a low-grade primary hyperpara, because if the PTH is not fully suppressed below 20, that would be considered abnormal parathyroid function.
So should the calcium be monitored, or should they
They tell them to cut back on their dietary calcium? No, I think that doesn't make sense. Pills, I would say, yeah. Pills, I would say, people with primary hyperpara don't need to take calcium pills, but you need to have enough calcium, from food, because the issue is kidney stone risk. And, if you have low dietary calcium, you get more oxalate absorbed, and that gets into the urine. See, but you have dietary calcium, it binds the oxalate, and you excrete it in the feces. So, dietary calcium should not be cut back on. Yeah, and if they take a calcium pill, they should take it with food, because then it would bind the oxalate in the food, and that wouldn't get into the urine. The oxalate causes kidney stones. That's it. Yeah. The level of vitamin D, you guys, we shoot for 30. The Institute of Medicine said, for the general population, 20. That's all the data we have. But I think there is, most societies, Endocrine Society, NOF, American Geriatric Society, say, no, shoot for a level of 30 with vitamin D. Okay. There's some very interesting data that in the New England Journal of Medicine that the vitamin D, we don't have this assay yet, but African Americans, you have ostensibly a low vitamin D, but because the binding protein is different, the free vitamin D is normal. So that can be tricky. I mean, again, until the jury's out, I'm not going to, I'm going to try to get people to a reasonable vitamin D level, and then, we can then try to verify that the vitamin D is causing a problem. If the parathyroid hormone is up, that's what we see, is that low vitamin D causes secondary hyperparathyroidism. So it's kind of how we replete vitamin D commonly. You basically 100 units of vitamin D roughly would raise the level by 1 nanogram per ml. You're comfortable with treating the vitamin D, right? Yeah. Sarcoidosis and primary hyperparathyroidism are two situations where you've got to be a little careful, because then they could hyperconvert, and they could cause hypercalciuria, hypercalcemia.
So we should get a PTH if we have a really low vitamin D, like we get a vitamin D that's just in a pen.
Yeah.
PTH, right?
But, you can wait until you fix it, too. But if you're in doubt about the clinical significance of it, you could try to get a PTH to see what it's doing to bone metabolism. So, but the way to get a PTH is what the doctor was saying about, when you get these patients with a high normal calcium, 10.4, they're losing bone, 3, suggestive that they have a mild primary hyperparathyroidism. And, if you take out the overactive gland, the bone density goes up. So, but we only do that, for certain indications, really. Yeah, protect the bone density, but. All primary hyperpara? Well, PTH is bone resorptive, so you're blocking that negative effect of PTH. But the problem is, we can't keep people on bisphosphonates forever and ever for unless they're elderly and matter. But so surgery is a good answer to the problem if you have indications like kidney stones, like fractures, like osteoporosis. We try to localize the gland, and
Can you cause the elevated calcium just from taking a pill, like taking blood?
Nah. Yeah, your body's pretty good at defending the calcium. There's something called milk alkali syndrome where people pop all these antacids, and that kind of can cause a high calcium as well and cause kidney dysfunction. Yeah, so total should be 1,200 from food plus pills, and less if they have chronic renal insufficiency. People with multivites, I count that. Calcium nephrolithiasis, you got to be a little careful. So we talked about this. So anti-resorptives, you know, inhibit the osteoclast, right? And, you know, the interesting thing here is that the bone density increase that they cause does explain the fracture protection as well as the reduction in this bone breakdown in the bone resorption. So I wanted to the bisphosphonate, you know, it accumulates in the bone, so it literally sticks in the bone, and you can see that here, you know. And so let's say you gave 5 years of Fosamax, you're going to have, it's the gift that keeps on giving, like we said, but eventually it does wear off, you know. And the studies that have looked at that, one study we'll look at real quick is 5 years of Fosamax followed by 5 years of nothing compared to 10 years of Fosamax. And let me just skip to that here. But this just shows you, by the way, you give reclass, you know, you suppress the bone resorption. They're giving it once a year in this study for years. So you see the bone resorption stays down nicely in the, you know, in the premenopausal range. Postmenopausal level of bone resorption and dropping it down. Okay. So these are the things that we're worried about here with long-term potent drugs like bisphosphonates and Prolia. Okay. You know, on the flip side of this, if you only give 5 years of Fosamax and stop, compared to giving 10, the people that stopped had more spine fractures, clinical spine fractures, and that was a statistically significant difference. So that's the thing, is that if you have a very high-risk person, you know, stopping because you're worried about this may not be the right thing to do. So the OJ incidence may be 1 in 10,000 to 1 in 100,000. So this is really very, very rare. Anybody had a patient who had this, ONJ? Yeah. Did it heal okay?
It did, but it's high-dose penicillin. You know, they're very, very high-dose penicillin.
Yeah.
For 2 months.
Yeah.
And then it healed. But she wasn't a cancer patient, so I was really shocked.
Interesting, yeah. Yeah, because, right, most cases, 95% of cases are cancer patients on monthly IV Zometa. Yeah.
There's some research that indicates that it's bacterial milieu in the mouth, even more than the...
Yeah, I think that's what happens, is that it's an osteomyelitis, actually, of the jaw, too. And it gets infected.
It's a dry socket. That's what I think happens. They get a tooth pulled. It's the dry socket that most people would get on medication. Dry socket. It takes months to heal. But when you're on this, it just accelerates very quickly.
Yeah. I mean, I can tell you in the big reclass study, 8,000 women, there was 1 case in the placebo and 1 case in the drug group. And, you know, so it was a wash. It was same as placebo in that study. And they were, I think they were, one of them was a poorly controlled diabetic. And so, you know, we don't worry about this too much in the osteoporosis world, but this is what we worry about a little more, is these iatrogenic femur fractures. And this is what they look like. See, it starts in the lateral femur as a stress reaction. So you can see here, you know, this little blip, right, in the lateral femur. And, you know, rarely you could even see it on DEXA if they go down far enough. All right, so that's the precursor to the fracture, patients complaining of thigh pain or groin pain. Okay, so you want to ask patients who have been on these drugs a long time if they have this kind of pain. Asian race may be associated with a higher risk, multiple anti-resorptive drugs. It can be bilateral and worse, right? I mean, you know, if you have, so this is, and cortical thickening on the lateral femur. On the lateral femur is what you would see. So this just suggests something distinct. Now, if we look here, you know, the FDA weighed in on this. These are studies of alendronate and then reclass, okay, Fosamax and reclass. So 10 years of alendronate versus 5, your risk of spine fractures is less, right? Because the risk on this side of it is less. Yeah. This is clinical spine fractures. That's what I was saying. Now, then if you look at X-ray fractures, well, no, it wasn't really less. It was in the middle, and then the reclass studies, the risk of clinical fractures was not any different because it's crossing the middle, but the risk of great fractures was less. The FDA thought that evidence was kind of inclusive. They didn't, they thought that you could getting a from these drugs is a reasonable thing. So 3 years of reclass, by the way, followed by 3 years of nothing is like the same in terms of bone density as 6 straight years of reclass. So they're very, they're buying there in the bone, and they keep working. So again, I think we want to avoid putting people on bisphosphonates plus estrogen necessary, and it could increase the risk of some of these case reports of these things have that situation. And, I think how the trend has, so women with osteopenia who are not at high risk, they should be treated for just thinking of these drugs as vitamins, so to speak. So you want to consider a drug holiday after 3 to 5 years. You can consider it, unless they're high risk, because we know that if you keep the Fosmax going past 5 years in high-risk women, you get less spine fractures than if you stop it.
So if you do 5 years on, 5 years off, then what do you do after that?
That's a good question. Nobody knows exactly. I think most people would consider getting something else, like getting, possibly, or you could restart. Nobody knows if the clock restarts into the risk for these complications after a holiday. But my sense is probably not. It doesn't reset to zero. Because I follow these markers, I like that. It gives me some reassurance. But when you're sending this to your patients, this is a slide from a bone guru from New Mexico. The fracture risk, the risk of fracture compared to fatal motor vehicle accident, murder, ONJ, and atypical femur fracture. If you got somebody who's got osteoporosis with a femoral neck T-score of -3, it's really, that's the perspective that we should take out of this. And everybody's an individual, though. They don't want to. Some people don't like drugs. They don't want to take any risk. And So here's a case patient before we finish, and she has osteopenia. Then her bone density was treated for 3 years. Bone density's gone up. T-score is a little better. All right. Would you give her a holiday? Basically, her FRAX wasn't high enough to treat to begin with. So there you go. So I wanted to mention this was that study of Fosmax, 5 years versus 10 years. And again, the spine fractures, these are clinical spine fractures. They're not X-ray fractures. These are painful, real spine fractures. So if you stayed on for 10 years, you had about half the risk of spine fracture in this study. It's complicated, right? You got to worry about this femur fracture. You got this data, and these are women that were older. I would say around 70 in that study, and had osteoporosis. Now here's another one. Okay, she's 72, T-score -3.8, 10 years of bisphosphonate, rheumatoid arthritis on steroids, 3-inch height loss, spine fracture, an X-ray, can't rise from a chair without the use of her hands. Holly? Yeah, Forteo. Yeah, Forteo's a good option there. You guys are all honorary endocrinologists now. Yeah, that's definitely a good option. Okay, so we talked about Avista already. I think one more case here this is Forteo. This is what Forteo does if you're curious. It's stimulating the osteoblast that builds bone. And, this is very strange.
I thought osteosarcoma.
Yeah, osteosarcoma is the thing with Forteo and FRAX. And so far, we've had a lot of experience with it. And there's one case out of 350,000 people treated, which is the background incidence of osteosarcoma. So in humans for 2 years, remember you only give this for 2 years, it doesn't increase the risk of osteosarcoma. If somebody has a history of recent cancer, I'm a little reluctant to give it. As this stimulates bone turnover, and that may be bad for microscopic cancer metastases and whatnot. But, you know, so hyperparathyroidism is bad for bone, so how could this be good? And this gives a pulse, so this causes this huge pulse in parathyroid hormone. You basically, there's this window of time where you turn on bone formation, and then bone resorption eventually catches up. So that's when you can actually use that drug to build bone. You can't give it, they've had radiation to their skeleton also, technically.
Radiation is done where, like, they've had breast cancer and they've had radiation therapy?
Technically, no. I mean, you know, because radiation increases the risk of osteosarcoma to a small extent. It makes my life challenging. I can't use it for a lot of people unless you want to have that discussion with them, you know.
But they don't know what the incidence of osteosarcoma is. Is that right?
No, yeah, I mean, it's unstudied, yeah. Yeah.
Let me ask you a question about, I have a 69-year-old patient who had stage 3, sort of very low-grade indolent breast cancer, had a mastectomy, radiation, was Fosamax prior to that, and was continued on Fosamax because she put on Femera.
Yeah.
But she now has compression fractures in the thoracic spine, so they switched her to Prolia.
Yeah.
And I was wondering, why wouldn't they support 12? Now we know.
Yeah, there's some, you know, right, she's had radiation, and there's some questions about, you know, patient with recent cancer using parathyroid hormone, yeah. There's a lot of evidence that the bisphosphonates, you know, may prevent breast cancer from coming back in bone. It's not crystal clear, but there was a big meta-analysis that suggested that from the UK recently. So it's, you know, it's our group hasn't said, oh, every single person in that situation needs.
You just have to worry about the atypical pain fractures, which are greater than
Yeah, I mean, you know, but that's the thing, you know, ask the patient, let me know if you have any aching pain in your thigh or your groin. You know, it starts as a stress fracture, remember.
Will the immunomodulatory antibiotic also be contraindicated in the event of cancer?
No, yeah, for radiation, no, I don't believe so, because that one is a different mechanism. Yeah, it works on this protein called sclerostin. So, I will. Yeah, I think it will be. Yeah. So this is our final patient here. It's page 65-year-old lady. She had a wrist fracture. She had 2 inches of historical height loss, no weight loss. I do ask about weight loss because some of these old folks, they just have the way kind of thing, and you know, muscle loss, bone loss, and fracture. So she has poor balance, right? Because we said you should be able to do this for 20 seconds. Everybody's going to try it, right? And her vitamin D is low. Her parathyroid hormone's high. And let's see, high enough risk for fracture. So how would you figure it out? Yeah, you could put in FRAX though, because FRAX includes the variable, have you had a fracture before? Okay. So her dairy intakes, you know, her calcium intake comes from pills, so that's okay. So I would split her calcium pills, try to get some from food, replace vitamin D, refer to physical therapy, and then her FRAX risk does meet criteria. It took away her history of wrist fracture. It wouldn't meet criteria, just as a FYI.
Is it 20%? Is that what's the...
Yeah, 20% for any major osteoporotic fracture and 3% for hip fracture.
You wouldn't put her on?
I would, yeah, because her risk is high enough per FRAX. Yeah. Yeah, but I didn't write that there, but I would. Good point. So this is the NOF's recommendations, you know, about checking for these spine fractures or vertebral compression deformities. So you've lost 2 inches of height. Do that. And, yeah, that's it. Yeah.
Thank you very much. Thank you.
I think that is a huge financial. And I didn't the town, but I wanted to. So when meeting is the first week of May. And then after the meeting, lecture. After the meeting, we're going to pay the extra so much money that.
I thought, what the hell, I might as well do this. I don't know how much I'm gonna look at, because I always have a great plan, and don't, you know,